My name is Jared Fields. I am the president of the Emerging 100 South Metro Atlanta. I would like to thank you for joining us tonight as we present to you Mental Health Matters. We will cover topics about brain and mental health, including depression and anxiety. So let's go ahead and get to it as we introduce our speaker. Dr. Dwight Owens is the chief psychiatrist for Peach State Psychiatric Services Incorporated. He received his bachelor's degree from Morehouse College here right in Atlanta. He received his medical doctorate from the Health Science Center at Syracuse. He then returned to Macon to Mercer University School of Medicine and obtained his internship certificate in family medicine. He then returned to Syracuse, spent a lot of time at Syracuse, and then he ended up completing his adult and general psychiatry training at Emory University. He is the author of Depression is in the Pews. Without further ado, I present to you Dr. Dwight Owens. Dr. Owens, how we doing today?
Oh, just great. How are you?
We're doing fine. We're doing good. We're doing good. I gave everybody a brief intro for you, so you go ahead and take it away.
Okay. Tonight we're going to talk about some very important things as it relates to mental health and understanding mental health and how it looks. We chose a broad array of topics tonight, so if you have any questions or if I say anything that you have a question about, we'll try to answer those questions. The first thing we want to talk about is give you just a brief history of some of the major diseases and phenomenology. So when you leave, you'll be certainly equipped with all you need to know about mental health.
Dr. Owens, my apologies. If I may, can I go ahead and alert the listeners to go ahead and submit the questions?
Sure.
All right. Please, listeners, go ahead and submit your questions into the chat. Dr. Owens will be glad to answer any and all questions that you have. So please feel free to enter your questions into the chat, into the comments, and then we will go ahead and read those questions to Dr. O. So thank you so much, Dr. O.
Okay. So the first topic we're going to talk about is depression. Mm-hmm. Depression is what we call a mood disorder. And essentially, it is, you begin to see a lot of different changes, psychological as well as physiological changes you can get with depression. There's a mnemonic that we use. There's something called SIGI-CAPS, and it kind of gives you a descriptive of what it looks like. Now, a lot of people feel like in order to have major depression, you have to have depression, and actually you don't. That's something that you're going to learn on tonight. First, I want to tell you that when you think about depression, you have some other kind of discriminating factors. You have grief, and then you have depression, and then you have something that we call smiling depression. Smiling depression is when, the person has issues. They're sad. They have a lot of, they're kind of irritable or they're kind of isolated, and they don't really want to admit to the disease or the phenomenon of depression. So they may be smiling, hey, everything's all right, I'm good. But in the actuality, they're not good, because depression is a medical illness. And when depression is not treated, it can have an adverse outcome called suicide. As we know that right now, the suicide rates are going up in some demographics. So we're trying to really address this by educating you, like we are on tonight, on what depression actually looks like.
So Dr. O, if I may, so my first question would be to you, is there a way to catch it? Like, what are some early signs of depression, if possible, that someone can catch, okay, like for their loved one or a friend?
So those are some of the characteristics, like sleeping a lot. Mm-hmm. You find people who sleep a lot. Then the other is they don't sleep a lot. Um, these people can also have this guilt. Whenever you talk to them, it's like, the world is no good. I'm no good. The future's like hopeless. Then the energy, you never have any energy. When you go by the desk, they have the monster drinks and the 5 hour energies. They have problems concentrating. So you're in meetings with them, or you say, "Hey, can you pay a bill for me?" And they go to and forget to pay the bill, and they have the money with them. So all of these are some early kind of signs that can cue you in that there may be something going on with that person medically. And remember that depression is a medical illness. And we really are pushing that nowadays because a lot of people and when you say the word mental health, it looks like something that is somewhat taboo. And it has been taboo in some cultures for a long time. But now we're really trying to train people such that they understand that depression is not simply taboo, but is something that really needs to be dealt with and addressed.
Mhm. Yes, doctor. I truly believe that. I think a lot of times, along with that taboo, I think. Well, let me ask you this: as far as patients go, more so cases, I should say. Are there a lot of people that are in denial? I guess is that a part of the taboo? Like, is there a lot of people that when they come to you and they speak to you about their mental health, do they feel like that? Do you feel like they're in denial when they speak about it?
Well, if you come see me, you're probably not in denial. Um, right. Because hey, I'm a psychiatrist. So
Right.
by the time you get to me,
Mhm.
you're probably not in denial. You're probably ready to address the issues.
Mhm.
Now, men are different than women as it relates to depression. Women go to the doctor. And
Yes.
so oftentimes women have different avenues. They have the primary care doctor, they have the OBGYN doctor, and they also have the actual psychiatrist. So they can go to different places and get help, whereas men tend to not go to the doctor. And so for them to get to the level of a psychiatrist, there will probably be a lot of distress that's there. So remembering what we talked about: sleep, lack of interest, guilt, low energy, concentration problem, and eating. You find yourself overeating. A lot of people overeat to cover emotional pain. So you'll find a lot of people that eat just all the time, a lot of obese people. And once you begin uncovering the obesity, you're going to find probably some things like early childhood trauma. These people can also have the dreaded suicide thoughts. And that's what's bad, because nowadays, if you have the energy and the impulsivity, then people go ahead on and complete suicide.
Wow. Wow. Yeah. Yeah. That could be a lot. So let me ask you: can we is touch on anxiety?
Okay. Anxiety.
Yes. Yeah. And the reason why I bring it up is because I know a lot of, like, I know you hear a lot about test anxiety or performance anxiety, et cetera, like that. So, can you speak about anxiety?
Now, anxiety, you have two types of anxiety that we listed for tonight. We talked about the anxiety and we talked about the panic disorder. Both of these are
Yes.
anxiety disorders. Now,
Mhm.
when you look at how we are composed, we have a conscious and an unconscious.
Mhm.
And within the conscious and the unconscious, you also have what we call the superego, the ego, and the id. Now, anytime there's a stressful issue, something that pushes on the unconscious, the part that's in the ego, you can begin to experience what we call anxiety or discomfort. Anxiety can manifest itself in ways such as heart palpitations, nervousness, nausea, vomiting, hair loss, irritability, brittle nails, a lot of things anxiety can manifest itself as. So you'll begin to see that particular kind of thing. And there's a generalized anxiety, which as we get older, a lot of people develop that. They're just always nervous. So when you see a person that's always nervous, that person probably has what we call generalized anxiety and probably needs to be treated. Now, the panic disorder or the panic attacks, that's a different type of anxiety. What happens is you usually get an extreme physiological surge, but it's also due to some unconscious conflict. It could be something that's deeply embedded that's trying to manifest itself. And the way it pushes is it pushes out in a physiological response. So you'll get stuff like shortness of breath, heart palpitations, hand sweating, dizziness, nausea, vomiting. Now, the panic comes intense and it will wake you up in the middle of the night, or you find yourself driving and you'll just boom, boom, boom. So the panic disorder is more disabling. Now, both of them are caused by conflicts in the unconscious. When you remain with what we call reality testing, you know what's real and what's false. Because if you have a what we call a quote unquote nervous breakdown, that means that your reality testing is now impaired. And that becomes a psychiatric emergency that has to be treated, more likely so than not in the inpatient setting if it's something that's more acute. Panic attacks or panic disorder. A panic attack peaks out at about 30 minutes. So what happens is you get this intense surge. So about 30 minutes, it should peak out, but it can go from 30 to 45 minutes to an hour, but then it begins to curtail. But what happens when you have a real panic kind of episode, it'll linger around for a while. Just linger. And usually all day you'll feel like kind of an out-of-body experience. And that is because there's a fear of having another panic attack. These are very disabling for people that have them. And people don't really like to go out or become agoraphobic because, you know, there's a fear that if this happens again, it's going to be disabling to me. So what you find out is that that's one of those tough ones. So anxiety, there's a generalized anxiety. The panic disorder is more intense, but it's the same kinds of symptoms, but they're just more intensity in the presentation.
Wow, thank you. That was very informative. That's extremely informative. My next question, I'm gonna break it up a little bit. So let's hear a little bit about Dr. Dwight Owens and what made you choose mental health to pursue out of all the different areas you could have pursued.
Well, initially I was going to go into family medicine. But as you know, when it comes to family medicine, it's like kind of like there's a lot of different things or everything. And, you know, I thought about it, and then I decided, you know, some circumstances to change my way of thinking and try to narrow my focus. Now, when I first took psychiatry in medical school, I was like, I can't do that. There's too many medications. There's 1,000 medications. So I said, so many medications, you know, you got medications for anxiety, medications for depression, medications for schizophrenia, you know, and medications for dementia. So I was like, it's 1,000 medications. But I decided that I really should give it an opportunity because there are a lot of cross-cultural issues in psychiatry. And a lot of people are not aware that, hey, we have to treat this medical problem. We can't just shout it out, or we can't just drink it out. So you see a lot of substance abuse in our community. You see a lot of aberrant behavior. You see a lot of irritability, a lot of divorce, a lot of fathers in absentia. All these can be driven back to some level of trauma or distress in a person. And so when you have a person that can identify with your culture or that understands certain things, like why you eat potato salad for Christmas or whatever, then you feel more comfortable. And a lot of times when I have patients, there are patients that see me because they want someone that can understand them and who they are.
Yeah, which is going to roll me right into my next question. What are like some myths that where we can debunk about mental health? Because as you mentioned earlier, it's taboo, and a lot of people feel mental health is fake. A lot of people feel it's not real. But as we all know, and I'm glad that you know, of course, now in 2021, a lot of people are taking their mental health very seriously. So, what are some myths that that we can debunk tonight, Dr. Owens, about mental health?
The first myth is you really can't just shout it out. You know, I have a book, and my book addresses that, where, you know, in our culture, we want to pray away the demons of depression. That may not happen. So you have to address it because it's a medical problem. The other thing is that somebody has said something about African American Black people don't go see the psychiatrist. Now, I don't know who that is because my schedule is packed. So believe it or not, that friend that's telling you they don't go to the psychiatrist, they might go to the psychiatrist. So that's another myth. The other one is people talk about medications, and medications cause side effects or make you groggy. If you find a good doctor, find out how he handles his medications. I'm very conservative, so you'll never know my patients are on medication. You just won't, because I know how to dose the medications. I know how to make some changes related to cross-cultural changes and issues. Because if you look at, we are the black men, for example, 100 black men. You look at most of us, we have a huge body happiness. Most of us are big, but we require the smallest amount of psychiatric medications because African American men are what you call slow metabolizers. Now, if you find a person who doesn't quite understand this phenomenon, what you're going to have is they're going to be over medicating the black male, and that causes side effects. So you don't want to do that. So know this, that African Americans do see a psychiatrist. Another myth, it's going to go away. It's going to get better automatically. Not all the time. If you have clinical depression, a major depression, it doesn't just go away. Depression causes the most missed days from work than any other medical problem in America. Let me repeat. Depression causes the most missed days from work than any other medical condition. Cancer, HIV, heart disease, it causes the most missed days. That lets you know this is a pretty serious medical problem. So it's not going to just go away. So those are three big myths that we can kind of help on tonight with.
Yes, and to go along with your with those with your comment about the days off from work, how that is the number one, how depression is number one. I've seen, just of course, just being in corporate America, I've seen a lot of companies shift towards unlimited PTO days, and I've seen them shift towards mental health days and self-care days, or whatever their company wants to call them, and they're advocating more for mental health. I know specifically my previous company, they offered the service BetterHelp, and that helped as well. Just giving just a different. I'm saying all this to say that these companies are taking the step towards trying to at least help their employees somewhat sustain their mental health. I myself personally, my personal journey, I dealt with anxiety in my past. So again, it's just funny that you brought that up, because you brought up about how your calendar is filled. Again, being a black man, I was surprised with seeing how many people were in that office with, I'm talking about nonstop appointments. We're on the clock. I'm standing appointments at that. So, a lot of people, as you mentioned, a lot of people may feel like, oh, people don't go, or maybe African Americans don't go to the psychiatrist, but trust and believe, y'all calendars are booked up. I know at least when I was in undergrad, I remember I have a friend who ended up getting his degree in his undergraduate degree in psychology, and he like, how am I going to be a therapist? But back then, as of course you would know because you've been in the field with so much experience, back in those days, we're talking like the 90s, early 2000s, mental health was old. That again, that was the let's pray it away. That was it's not real. So to think that that's what it looks like and actually see what it looks like in these offices is good. And it also shows that, at least we're trying to head towards the right solution. Mm-hmm.
Right. And, the thing about it is, I think what we try to do is we really have to understand the needs of the culture. And if you understand the needs of the culture, then you can better approach a patient. A lot of times when there's an acute stressor, the response that you're getting is based on a previous issue. There's a phenomenon that we talk about called epigenesis in psychiatry. And what that means is that if you don't successfully achieve the response to the previous traumas, you're going to find yourself like almost in a cyclic pattern of distress. It's like, for example, every time you get into a confrontation, it's always this hyper response all over. And those people have not learned from their past experiences. Now, some people can, say, you know what, I need to chill out. I need to relax. I need to calm down. But then others, they may have to learn through therapy, through training, how to deal with conflict, how to resolve conflict, and understand that um, it is something that we can work through, and working through the processes and working through the trauma. Because generally speaking, when you see a person that has like some hypervigilance, there's probably some trauma that has not been dealt with. And we do different things with trauma because a lot of times, because these things are not resolved, it leads into other things like the anxiety, PTSD, depression. So there's a lot that's there that we have to kind of work with.
Wow, that was good. So I'm going to throw a curveball at you.
Mm-hmm.
Children. Do you see children, or do you stick only adults?
I do see children.
Okay. So my question is, for the parents that are watching, how are the parents? Let's start with depression. How can a parent notice depression in their child? Is it the same symptom as an adult, or would they differ as a child?
Sometimes when it comes to children, you will see more irritability. I never forget the first time I saw a patient with depression. And she was in a room and we were watching her for play therapy. She literally destroyed the room. And it was amazing to see all this energy. But then we began to drill down on it. We saw something different. So that's why I'm very cautious at saying ADHD real quick. Everybody wants to be ADHD. Your mom, your daddy, your sister, your brother. You notice that's like taboo. Oh, I got ADHD. No, you don't. You probably have something else. But ADHD is vogue right now in America. So everybody has it. But when you really begin to sit and talk with people and some of the children, you'll find out that there is a mood disorder that's there. So when it comes to kids, it's a little bit different. We see manifestations of course, ADHD. There's something called DMDD, or disruptive mood dysregulation disorder, and of course, trauma. Now, one of the theories of depression is loss of a parent before the age of 12. So when a child loses a parent, whether that's through divorce, whether that's through death, whether that's through fathers in absentia, all of these things can lead to a mood disorder. So when you deal with children, you have to get what we call a good biopsychosocial workup. Where do they live? Who do they live with? Are they in the Boy Scouts or in the Girl Scouts? The mom involved, the dad involved, who raised the kids? Because we feel like as long as grandmama's raising the kid, he's in good hands. That may be so. But you still have to realize, Freud taught us something very early. Every child wants a mother and a father. And when they're not there are all kinds of compensatory coping mechanisms that can be either good or they can be bad. But the one compensatory mechanism that doesn't work is something called anger. So what happens is I'm angry. Everybody else has a mother, a father at PTA. I don't have one. So that child becomes angry, disruptive, causing problems. So they're very angry little kids. But what happens to the anger that doesn't get resolved? It becomes turned inward. And anger turned inward is one of the primary phenomena for depression.
Dr. O, I think you're about to light a fire right now. You just touched something about the ADHD, because you do hear ADHD thrown around a lot with children, which brings up, if you don't mind, before we shift to anxiety, you brought up, let's talk about ADHD medications. And do you feel, again, I'm not sure, again, if you can't, comment, then don't, but if you could, do you feel that a lot of children are misdiagnosed, number one, and then number two, forced to take medication.
I don't know about forced to take medication. That's something that's illegal. But
my apologies, not forced, but I mean persuaded, like, hey, you should put your children on medication.
This is what I think.
Okay.
When it comes to ADHD and the psychostimulants, they calm children down. So when you have a child that has depression, anxiety, all these other disorders, the parents and the teachers want a quick solution. So a quick solution would be a psychostimulant: Adderall, Vyvanse, Concerta, Ritalin. They calm the kids down. Now, they also do some other things, such as can stunt growth, headaches, appetite disturbances. There are a lot of things that stimulants do, but for that calming effect, people are very happy. And that is a problem. So before I diagnose any kid with ADHD, I need school records. I need the parents to fill out certain forms for me so that I can be sure that this is what it is. And I have to kind of get some records from the teachers. And one thing that I look for is I look for the IEP or the 504. If you don't have one, you probably won't get no medication from me, because it has to be in separate settings that we've recognized that this is an issue. And the forced medication, I don't think they force them, but the medications do work. They do calm kids down. But the problem gets to be if you calm the kid down, but the kid does not get the knowledge he needs to progress to the next level, then you got a problem. So you just got a quiet kid sitting in the corner, but he's not learning anything. And that's my problem with the overdiagnosis of ADHD.
Whew. Yeah, that was very heavy. I'm pretty sure you might get some inquiries after this event, Dr. O, because you are hitting on some real strong points that I think that African American community can, one, relate with, and two, feel similar to you about. So definitely thank you for that. Now again, I want to ask the listeners to please put your questions in the comment section or in the chat so that we can read them. Also, please do not forget to complete the survey on the Eventbrite. The listeners. All right. So, what type of test can be performed to? Well, first, I'm sorry. Let me ask you this. What are the types of tests that are used to tell if someone has depression or anxiety, et cetera, Dr. Can you kind of walk us through that, or like how that will look?
Okay. So basically, when you come to see a psychiatrist, I recommend seeing a physician first. And the reason for seeing a physician is he needs to do basic lab work, because there are great imitators of depression. For example, I had a patient with she had some thyroid issues, and she wanted to tell me how the thyroid works. And I let her tell me how the thyroid works, but I had to back her back down. So I told her, what you do then, go back to your endocrinologist and tell them that if you have hypothyroidism, can you get brain fog and depression? So of course, when she came back today, she was like, yeah, but I was trying to tell her that it is certainly important that you get a good physical, because multiple sclerosis, hypothyroidism, and some other diseases, and even some of the side effects of the antihypertensive medications can cause depression. So once you get that workup, then you need a clinical examination from a psychiatrist. So one test we use is the PHQ-9. That's the most common one, the PHQ-9. So that's the patient health questionnaire. I mean, it's about 9 questions we can ask you quickly. And based on your responses, we can categorically place you in a different area to see where you are. So that's a simple way of doing some objective testing. Now, if you want to, you can go tonight, Google PHQ-9 and take the test yourself and see where you come. There are a lot of other tests, but we don't try to get too fancy, because what the biggest way we're going to diagnose this is through clinical presentation. So we're going to find out exactly what is going on with you over the past 2 weeks. And there is a temporal kinds of things we need to know: how long you've been experiencing symptoms, as well as what symptoms. And it takes 5 neurovegetative signs and symptoms plus depression and or anhedonia. What is anhedonia? You don't want to do nothing. I don't want to do nothing. I don't want to go nowhere. Call me. No, I'm going to go out. I don't want to go dancing. I don't want to go eat. I just want to hang out at home. COVID's out there. I'm scared of COVID. So after a while, it gets to be a little bit more than basic fear of the disease or just want to stay at home. Once you have loss of interest in all activities, loss of interest in sex, loss of interest in eating, then you're looking at somebody who more likely so than not has clinical depression.
Now, Dr. O, you just touched on a point. I want to ask this question from the group first, and then I'm going to come back to your point. So we have a question from the chat, and this is in reference to trauma. What are some examples of traumas of depression and anxiety? And what do you like that question reworded? Because what I'm thinking is, what are like some traumas that causes depression and anxiety? I guess is that what the question is trying to ask. Mm-hmm. I think you're on mute, Dr. O. Mm-hmm.
A trauma can be something that is actually experienced or visualized. We're going to open up the can of worms, but trauma was not on the list tonight. I was invited to put it on. But trauma is anytime there's a issue that is life-changing. Sexual trauma is the big one. Car accidents, motor vehicle accidents, sudden death. These are all things that can change the neurobiology of how you respond. So a trauma usually gets into the neurobiology of the brain because now you don't respond the same way. When a person has a bad trauma or what we call shell shock, they become always on edge, jumpy. They have flashbacks, they have nightmares. There's avoidance, they don't want to go anywhere. So it can be pretty bad if there's a trauma that hits into the unconscious or the conscious and it begins to manifest itself. So the PTSD triad is hypervigilance, avoidance, and flashbacks and nightmares.
Okay, so now to the point that you did bring up, you brought up COVID depression, correct?
COVID dysphoria.
I'm sorry, COVID dysphoria. Mm-hmm. I believe that is very prevalent. Is it okay if we touch on that a little bit? Because I think a lot of people, in these current times that we're dealing with, we're currently coming out, with the masking, the CDC updates and everything going on. Can you touch on COVID dysphoria, please?
Okay. COVID dysphoria it's a type of depression that people are experiencing secondary to what we are experiencing at this time with the pandemic. So you have symptoms like, don't want to go out, feeling sad, weighted gloom, doom, hopelessness, helplessness, guilt. So it's a type of depression that's more specific to the phenomena of the pandemic. But depending upon the manifestations of that disease, you still have to treat it as a major medical problem. And you probably should see a psychiatrist to be sure that it is what it is. I have patients, that just don't want to go out. They may go to the mailbox, but they don't go anywhere. And it's because they are really concerned with what has happened over the past 12, 14 months. So that is a dysphoria. You just feel like gloom, weighted. You can't quite get together, brain fog. Things are dim for you, dimly lit for you. So that's how we look at the COVID dysphoria. Yeah.
And I assume your caseloads probably have been packed with a lot of your cases dealing with COVID dysphoria, and also I know Another part that you have to factor in is a lot of people that are returning to the workplace that are no longer remote. I know a lot of people are dealing with that, and I can't imagine the type of anxiety that may come with. Speaking about anxiety, we have another question from the chat, and it says, "What are some good ways to deal with anxiety?"
Well, the first thing you got to do is find out where it comes from,
Mhm.
and that's going to be uncovering in therapy. Once you bump it up a bit, you want to see one of us. We have what we call SSRIs, or selective serotonin reuptake inhibitors. The most famous one being Prozac. But we have a lot of new drugs since Prozac. So Prozac is what we used to use, but we have Lexapro, we have citalopram, we have other SNRIs, we have Wellbutrin, we have a lot of medications that we can treat. But the way we treat anxiety and psychiatry is with a medications and with something called cognitive behavioral therapy. What is that? Well, cognitive behavioral therapy is you got to look at a person and say, hey, look, you got a bunch of negative thoughts. So we need to find those negative thoughts and deal with those negative thoughts. And there's a process. And cognitive theory is this, I am bad. The world is bad. The future is just hopeless. So when you begin to see people who are always gloom and doom, they probably need some cognitive restructuring. They need the way they think. And we have, it's called automatic negative thoughts. And another thing you'll find out with these kind of people is they have catastrophic thinking. It's like, okay, everything, the end of the world is coming. The world is on fire. So catastrophic thinking is always what if, what if, what if. And people that have a lot of that, they really can't get themselves out, and they find themselves getting more and more wound up in the day. And by the end of the day, they're a wreck. So you have to treat the anxiety by first recognizing where it comes from. Because always remember that you can have medical problems that present as psychiatric phenomena. So you have to treat the medical disease, and then you treat the anxiety or the depressive disorder. So that's why you should start with the doctor. Now, if you think you got just garden variety depression, got your physical, everything looks okay, you go ahead onto a therapist. But you really should start with a physician to be sure there are no other rule outs before you actually go into actual care, treatment, and services.
Ooh, you got these questions coming. All right. The next one is a good general question that I think that would definitely be very good for everyone to hear. Is there a certain suggested cadence or a certain amount of times that a person should see their therapist? Weekly, monthly? What do you suggest? And first question, what do you suggest? And the next question, what is the reality that you see?
I'm gonna flip it on you.
Okay.
The reality of it is, if you're paying using your insurance is going to give you only so many visits before you have to pay. That's the reality of it. What I suggest is that you meet with your therapist. Now, if you're just doing therapy, you should meet with them as much as you need to. If that's twice a week to get you out of a crisis, go for it. If that's once a week to get you out of a crisis, go for it. Because what's going to happen as you begin to feel better, you will probably decrease the frequency. Now, when it comes to seeing the doctor, because you don't have a whole lot of psychiatrists, you probably won't be able to see us unless you have, now, like some people, they want to pay for circumscribed sessions. They want me to be there every day. Hey, fine with me, but I don't take insurance for that. But if you want to see your therapist or your doctor, you can determine that in your treatment planning session. And if you are a patient who, paying out of pocket, you probably can do as much as you like. But sometimes the insurance companies may limit the number of sessions you have in a year's time. And then you have to be on your own. But the average person sees their psychiatrist monthly, and they may see their therapist weekly or bi-monthly.
Is there an age? Because as you brought up earlier, I believe you said, I'm not going to even quote it because I haven't taken psychology in years. You're the pro on this. So what I am going to say is, I'm going to stick with my question of how early can these mental health and brain and mental health events, I'm going to call them, how early can they onset onto a child, I should say? Because of course it starts as a child and then it manifests as it get older, as I assume.
Well, there's a whole discipline of psychology that talks about learning and memory.
Mhm.
The incident happens if that incident or trauma ingrains and cause neurobiological changes that can be the beginning of disease. It's just like if you break your arm, disease. If you get cancer, disease. So whenever the trauma hits, that can be the beginning of your disease. You know, three, two. Um, you just say a child is in a fire. I mean, it just doesn't. That's just not going to be removed out of their mind quickly. So there is no particular age that's a magical age of 8 when we do. No. You can a child at 3, 4, 5 can begin to show manifestations of disease. And so what you want to do is that's why it's important to be seen and get an evaluation and workup by a physician first. And that's what I say by me because um, I would say when you see a physician, they're gonna look at everything in the course of your treatment, even your child development. You know, when do you start walking? When do you start talking? How old you said your first words? You know, is it normal development or is it some abnormal development? Because you know, we began to see developmental disorders, autism, Asperger's. I mean, there's a lot. So you really want to get that good workup in the beginning.
Yeah, we're actually going to get to one of the best portions of this event tonight, and we're going to talk about your book. I'm going to knock out about 2 more questions, about 1 or 2 more questions. Then we're going to hear about this book that you wrote that's on Amazon, by the way. But of course, Dr. O is going to speak about that. But a 2-part question just came from the from the listeners. From your perspective, has COVID made receiving therapy more accessible to families? And do you know of any programs or initiatives that people of color, POC communities would show?
Okay.
Mm-hmm. Yeah, see, it's a 2-parter, so you gotta.
Yeah. Well, let's do the first part.
Yeah, let's go part 1.
Most of the insurance companies are doing something. They're waiving copays, so you can see your doctor now, psychiatrist, therapist, and you don't have to pay a copay, because a lot of people were not coming to see us because they have $50 copays, $20 copays, and they could see us. So even as late as today, I know for a fact they start waiving them like in March of last year. They're still waiving a lot of the copays in this particular era. So in that way, it has become more accessible. Are there programs or initiatives? Well, 100 Black Men, you know, we got an initiative we're teaching and training on tonight. You have the National Medical Association that's there. The National Medical Association is the cohort of African American physicians in America. You have the APA, the American Psychiatric Association. You can go through them to find your doctor. And you also have NAMI. So it's basically the accessibility will be based on the community that you're in and what you're looking for. So there are limited providers. I will say that, to be honestly with you. But if you really want care, you can get care. Now, there are some, issues such as your ability or your resources, insurance, and some of those kinds of things are important and can be a barrier. Because, say, for example, people say, well, Dr. Owens, you see patients who don't have insurance. Well, the problem would be not that I don't want to see you, but if I see you and you need medications, then what happens? Because I don't have medications. I do have a few samples, but you need to be on medication. So the likelihood of getting into some providers when you don't have medication, any kind of insurance, will be less. But if you live in Atlanta, that's Fulton County Mental Health, and they have a lot of resources that can help you. If you live in Cobb, there's the Cobb CSB, Gwinnett, Rockdale, Newton CSB. So there are mental health services, the CAB CSB. So in every county, there are resources for people who may or may not have insurance that want to get in a timely fashion. Because sometimes when it comes to private practitioners or some private programs, they will require insurance or a form of remuneration for their services. So yeah, there is access, but you just have to go for it.
Thank you so much. I know somebody benefited from that other than myself. That was very, very, very important information that we definitely needed to know, because we definitely have a lot of families. And that's one of the main reasons why we're happy to have you tonight, so that we can have those parents of those children, of course, that we serve in our programs, and also, of course, fellow members and our family members who are currently watching. They definitely need to know that type of information to help get the help that they deserve. Now, Dr. O, please tell us about your book, Depression is in the Pews.
It's depression in the pews. It's in the pews.
I'm sorry, in the pews. I added a word.
This is a book that took me a little while to rewrite. But it has a slant, of course, to the African American community, because I'm talking about something that's very dear to my heart. I am a elder in the church. I'm a Sunday school teacher. But one thing that we don't talk about in our communities is depression, bipolar, anxiety, schizophrenia. We don't talk about those things. And what we would do is, when Uncle became schizophrenic or psychotic, we put him in the attic, and he was never around in any of the family activities. But after you got old enough, you take him his plate upstairs and slide it up on the door. Or if sister began to act a little strange or bizarre, we sent her down south to live with a cousin, and she doesn't come back anymore. You don't see anymore. So we never talked about these things. So this book really just exposes the church. We got a problem. We got a lot of depressed people in our churches that are coming every day, and sometimes several times a week, but they're not getting better. Depression is not something that is mystical or poof, the magic dragon. It's a medical problem. And if people don't begin to see it as a medical disease, and they begin to see it as something that's just taboo, we're going to have a lot more disability, and we can have a lot more sickness, and there's some adverse outcomes, what I call death or suicide, or death by suicide. We now have to have the discussions, because the distress is different. Driving while Black, that's a psychiatric phenomenon, because a lot of us that are Black, when we drive, we see a police car, our heart begins to beat fast. I can guarantee you, if we survey the audience, we find out that of the African American men that are on here, 80 to 90% of us, when we see a blue flashing light, we become anxious. Because if it's a nice new car, they're gonna stop you and ask you all these questions. Like they asked me, did I have $10,000 in my car? Did I have a gun? Did I have drugs? I'm like, dude, I have on medical scrubs. I'm coming from the hospital. But I had to go through, and he was gonna write me a ticket. So I said, hey, what did you write me a ticket for? He thought about it. He said, oh, just go on and go. Because I had no idea. But my anxiety level at that moment in time was probably high enough for me to be diagnosed with generalized anxiety. But the issues that we're experiencing, this book basically, a lot of the questions that you're asking me, like what is depression? What is anxiety? A lot of those things are covered in here. And it talks about depression being a silent killer. It's a silent killer in homes. It's a silent killer in communities. It's definitely a silent killer in the church, because people come to the church looking for hope and help. So what I'm hoping is that through methods like this one, through symposiums and seminars, we can talk about this stuff. We got to draw the floor, because if Sally got touched by Uncle Bobo when she was 10, it's just not going to go away.
Dr. O, you you are definitely right on time with this message. You are definitely right on time with this book. You just covered some very real topics. Specifically, I'm going to call it what did you call it? Driving anxiety or police
I call
movie.
it Driving While Black. That's
Driving While Black.
yes, you know.
Yes, yes. I'm very familiar with the feeling. And mind you, your registration it could be legit. Your driver's license have no points. Everything, your car's working, your tag is up to date, and still when those lights cut on behind you, your heart start beating. I totally understand this. It's crazy that's what we have to deal with. But yes, you're totally correct. Hey, do people come speak to you about Driving While Black? Has that ever been brought up?
If you now, some people end up. Now, I'm a forensic psychiatrist, so I do litigation as well for people who have been maltreated or stressed in the workplace or whatever. So, yeah, I have had people who were arrested, false arrests. That can be traumatic because if you have all your stuff in place, and it's a matter of mistaken identity, going to jail is not fun. And so that experience in and of itself can be life-changing, because when the game is being played and you have to end up going to jail or whatever, now you got to go to court and miss work. Now you got to come up with the money to get a lawyer. It's all these different kinds of things that could be of a domino effect. So sometimes people do come to see us because some people don't want to drive no more. I mean, once you've been stopped so many times, when I was in Syracuse in medical school, I had a Nissan 240 SX. And every other week, I would get stopped. And they'd ask for my driver's license. So how do I get them to stop? So what I did, the last time they stopped me, instead of letting down my window, I cracked it and I slid my driver's license out. And he got insulted. What you think I'm gonna do? I said, well, you stop me every week. Same car, Georgia tags. I'm not from Syracuse. I mean, you know me, but you stop me every other week. I don't smoke. I don't drink. What do you want? So, and the fact that I can recall it, probably means it was an event that's embedded in my unconscious. So what the book tries to do is it tries to familiarize you with stuff like bipolar, which I think is on the list for today. What is bipolar? What is the difference between bipolar and major depression? How does it look if your pastor is depressed?
That's
the magic dragon.
Right.
Everybody know it. We're having this phenomenon where pastors are completing suicide. And once a pastor completes suicide, it does not only affect his immediate family, it affects the entire church. And then it shakes your faith. Because you had this man or woman of God in front of you talking about how wonderful God is. He's a healer, he's a deliverer. But then you take your own life. And then there comes the question, well, is he going to make it into heaven or is he not going to make it into heaven? Because he murdered himself. That's a deadly sin. So your faith now becomes shaken because the person that was between you and God just killed himself.
And unfortunately, I have heard of some pastors take their lives, and it's sad. But like you said, it definitely draws that big question mark of, now what do I do? Because again, to reference your book, back to your book about depression in the pews, that definitely brings up a real big issue. So my question about your book is more so of your inspiration. What inspired you? What did it hit you and say, I need to write a book about this?
The Facebook inbox. Everybody was asking questions. Okay, hey, you think I'm depressed? Hey, can you be depressed and a believer in God? Hey, I'm faithful in the church. What you think I happen if I tell the people I'm depressed? So you get all these kind of questions. And so I was like, hey, let's just jar the floor. Let's just remove the covers, remove the shields, and let's have an open conversation. Let's have a conversation about depression. That's all.
Wow. Wow. Your Facebook, that's signs come from everywhere. Yeah, I totally believe that. Family. what are some ways that families can help reduce the stigma about this taboo and these myths of what depression, mental health can be? What are something that families could take away from tonight to say, I heard Dr. O, and this is what I want to do to start taking those steps to start getting my family in a better space mentally?
Well, we need to first educate ourselves. First of all, a lot of people have no idea what depression is. It's like sadness is not depression. And the book defines that. What is sadness? Sad, I flunked the test. Took a test, had a big biochem test, got a 68. That ain't gonna feel good if you're trying to get to medical school, you ain't pass this test. But you think about it, get to the next test, you make an 80, it's gone, done. Depression, it looms. It looms. It's like you get up in the morning, it's like, I do not want to go to work. I just can't get out of bed. You stop bathing, stop brushing your teeth. It's like everything is black. Everything is dark. And so you're trying to figure out, I can't shake it. And you try to shake it, but you just can't shake it. And it goes on for 2 weeks. 2 weeks is the magical number because I'm losing weight. Man, I keep losing weight. I don't know why I'm losing weight. I ain't working out, but I'm just losing weight. Could be depressed. Man, I can't sleep. I went to bed at 10 o'clock. I tossed and turned all night long. Could be depression. Man, I lost my mom. I didn't get by there enough. And she called me and she asked me to bring her just a bag of Lay's potato chips and a Coca-Cola. I didn't get by there. And my sister called me and told me my mom was gone. Man, I was devastated because I wasn't visiting enough. Those are the kinds of things you can't shake. And there has to be a process, or what we call a catharsis, to help you move past your pain. Psychiatry is a form of medicine that it scares people because first thing you think about is a straitjacket or shock therapy, ECT. Now, ECT is some good stuff if you can afford it, get you right out of your depression. But that is not the first thing we do. We don't put people in the hospital involuntarily unless you're dangerous. If you're dangerous to self or dangerous to others, we will have to do something differently. But if you notice, when you talk about a lot of these shootings right now, it's like 90%, 100% of those people, well, I would say 100% of those people have some type of psychiatric or mental illness. When you look at Jeffrey Dahmer, serial killer, Sarah Smith, they got mental illness. So we have to begin to answer your question in family. We got to educate ourselves. We got to get a book. If you don't have to get my book, but get you any kind of book that's going to tell you what is depression. Now, I will tell you, this is not what you call an easy read, because when you begin to look, you may find yourself on page 10. And then what you got to do, you may have to fold that page back and make sure nobody's looking. Because the thing about education, it helps us to find ourselves and understand who we are in the world. So myself personally, I would get me something to read to understand. We got to read more. We got to learn more. CNN is good, but that's just a bunch of whatever. Sometimes it's just to get you anxious and make you all nervous. But you got to start reading so that you can understand more about who we are and how we're composed. Because now we're seeing racism and white supremacy. This stuff is going wild right now. But you have to begin to know now, is this affecting me on a different level? Because if it is affecting you on a different level, it needs to be addressed.
You keep bringing up great points, Dr. O, nonstop. We're getting close to the end, but we still have questions. Speaking of reading the book, we actually have a listener has your book. They're in the process of reading your book, and they want to know, how can we convince pastors, excuse me, how can we convince pastors to address depression in the pews?
Okay. So this is what you got to do. You got to be very smart because you really can't tell a pastor how to run his church, but you could do what we call health fairs. Now, if you notice when you go to a health fair, you're going to find the hypertension booth, you're going to find the diabetes booth. Get a depression screening booth. Like with our chapter, mental health is emphasized.
Wow.
And it has to be because what happens is a lot of these problems that we have come right from depression. 80% of the diseases are like psychosomatic. So in your church, if you having like just a little old health fair and you got the blood pressure cuff, you pricking a finger to check the diabetes, have a little station with PHQ-9s where people can check off. And if it is a little too high, then you have a card where to refer them to county mental health, a couple of psychiatrists or different places. So that's one way you could do it. Then you can invite speakers in to teach and to train. You can call a good psychiatric nurse. You call one of us doctors. We will come in and talk about it. I think the reason why it's not addressed is because there's nobody willing to go in. Now, I got to be kind of bold because I'm going to challenge your faith. You can be the best church member, pay your tithes, come to all the church programs, stay at Bible study, and still be depressed.
And that takes us to our last question from the listeners. That what you just spoke of, how do you address the guilt that people have with strong religious upbringing? So again, I'm pretty sure you're addressing in your book, the preacher's kids, the people who grew up in church, wake up, go to Sunday school, leave Sunday school, go to service, go to the second service, come back, go to watch, everything. So how do you help address that type of guilt, growing up in that type of household? Because of course, that's a lot of, or at least I've had conversations and I know that's what a lot of people have questions about.
Okay, so there's something in the book called the lack of faith theory. You got to attack that. Just because you having a medical problem called depression or anxiety, God forbid schizophrenia, that does not mean you do not believe in God. It's just like hypertension. It's just like diabetes. It's just like a broke arm. You have depression. And I think the one thing that I want to do in my little life that's going to last to be 100. Want to let people know that if you look at any psychiatric disorder, it's a medical problem. It's not something that's like some kind of mystical kind of thing. We don't just wake up and say, you got bipolar. You forgot to do the bipolar, by the way. We'll just wake up and tell people they got bipolar. There's a whole process of thinking, a clinical workup to get to the disease process. And once you get to the disease process, you work up a treatment plan. And the treatment plan helps you figure out how to get better. Because I tell you what, when you got a person with the mind got aberrations, their whole life is going to be kind of all over the place. You cannot have a healthy body if your mind ain't healthy. It just doesn't work. You can work out all day and all night, but if you got depression and anxiety and all those things, you're still not going to be a healthy person. You must have a healthy mind in order to have a healthy body.
My apologies. You are totally correct. We've got so deep into depression and anxiety, we never even had a chance to touch bipolar. Wow. Like you already mentioned, and then of course we were about to start wrapping it up. So can you just briefly kind of touch on bipolar depression, please? Because you're right, that is something that a lot of people definitely need information about.
Bipolar disease. So what is bipolar? Bipolar is indeed a type of mood disorder. But in order, different types of bipolar. I'm going to give you bipolar 1 versus bipolar 2. Bipolar 1, you don't ever have to be depressed. But you do have to be manic. What is mania? This is how the person, they're very irritable, they're nasty, they're difficult to get along, they're talkative, they talk a lot, pressure speech, hypersexual, spend a lot, all night long on Amazon, spending and buying stuff. Don't sleep. Don't need to sleep. They get them 2, 3 hours. They're up and ready to go, and they're grandiose. Hey, I'm on top of the world. So be careful thinking that a bipolar is a narcissist because they're very different. So we'll come back and tell you about personality disorders. But a bipolar 1 person is the whole internal system is rapid, and sometimes it can be rapidly psychic. And bipolar 2, you do have to have a major depressive disorder. You have to have a major depressive prong, and then you have to have hypomania. Hypomania is not as intense as mania. Now, the reason why we have to discuss this is because who's most likely to complete suicide? Someone who's major depressed or someone who's bipolar. Bipolars complete suicide much more than the unipolar depressed patient. The unipolar depressed patient, they don't have the energy. They just don't have the energy. Bipolars tend to be a little bit more impulsive, and they have a lot of comorbid substance abuse, cocaine, heroin, alcohol. So the alcohol, actually, when you look at a bipolar patient, they'll tell you the alcohol brings them down. But what happens is it also wakes them up once you finish swelling those cells up. So that's bipolar 1. Bipolar 2, you treat it with the mood stabilizer. But once again, you have to be sure, be cautious to see a doctor, because this is what can happen. You can think you have unipolar depression and you start on a medication, and all of a sudden you're real fast. Your mind racing, you're sweating, you're all over the place, you need to have a whole bunch of sex. It's like, I don't know what happened to me. Well, if you have bipolar depression and you start the person on treatment for unipolar depression, guess what happens? You flip them into a manic episode, and that's when you finally have bipolar. So you can't find out the hard way that you got bipolar depression, but nobody really wants to find it. That's why when you start medication, you come back to see the doctor so he can be sure that you have flipped over into a manic episode.
Dr. O, I hope people were taking notes tonight, because you just dropped every gem possible. Well, of course, mental health is extremely wide. It's a very, very large area. And of course, we didn't touch everything, but the information that you bestowed upon us tonight, Dr. O, a lot of people, I hope they were taking notes, because you gave us a lot. Now, we're at the portion of final comments. Do you have any closing remarks that you would like before we speak about how to locate you, how to find you, et cetera, et cetera? Do you have any closing remarks?
I just want people to know that depression is real. It is a medical problem. Don't be afraid to come out of the closet and talk about it. And we've got to have these, like tonight, frank and open discussions. They become important, because I think the more we talk about it, the more comfortable people begin to feel about it. We got to have the discussion around the dinner table. Hey, how you doing? You look we're a little anxious, a little on edge lately. Anything happen? And the one thing we got to do, we got to talk about what happened a long time ago. What happened in childhood? What happened on that first job? Why you don't like Uncle Johnny? Why you don't like cousin Mary Jane? Because we don't talk about it, but a lot of young men and a lot of men that are now 20, 30, 40 have been sexually traumatized, not only by men, but by women. We saw that in Antoine Fisher. So these things are life-changing. But we've got to start having those discussions. We've got to start talking about it, get it out there, make it open, make it visible, and get some help.
You, Antoine Fisher, Dr. O, I'm telling you, hitting on all pistons tonight. Antoine Fisher definitely was a great movie to use, a great example of that. That was great. All right, so do you have any contact information, any social media? Tell us where to find all the outlets, where to find your book. We pinned it in the chat. Please, everybody, go out and get Dr. O's book. Go ahead, have that, Dr. O.
Okay, so of course you get the book on Amazon, and I'm on Facebook, Instagram. My website is www.psychiatryofatlanta.com, and if you go to psychiatryofatlanta.com, you actually can make appointments. You can find out a lot of stuff I talked about tonight. You can go in there, you can see the different diseases, what's going on there, and you really can hopefully get some help. That's where I am. You'll see my posts. Sometime we'll talk about different issues to try to help people. But hopefully, what we've said tonight has been helpful.
Of course, I was on mute. But I would first like to thank you for your time, Dr. O. You have been great. This has been very informative, very fruitful. On behalf of the Emerging 100, Dr. O, and of course the chapter 100 Black Men of South Metro Atlanta and Emerging 100 of South Metro Atlanta, we want to say thank you so much for giving us your time to speak with us and to let us hear your story.
Okay. Well, thank you for having me.
All right, you're welcome. Have a great one.
Bye.
All right.